Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz, today, who's having some light difficulties as usual. But today we're going to be talking about shoulder dislocations and especially the reoccurring shoulder dislocations. Is there anything that we can do to potentially avoid them from reoccurring or happening again, especially for some of our overhead or throwing athletes? But before we get too much into it, Brandon, how's it going? The lights all fixed?
Yeah, we're good. As you started talking, I realized it was looking a little dim, and as you can see, the light behind me is on. We're having a nor'easter right now,
Yeah.
so it's dark and gloomy. So I was just trying to give the audience who watches us on YouTube a little better visual of my face,
Yeah.
which I don't know if that's always good, but if you're
Try and get more followers, not less. You're scaring them away.
listening to us on the podcast or audio, you're probably better off. We have a face made for radio. Is that the saying?
Yes. Yeah.
Yeah. Anyway,
Yeah, you and me both.
so shoulder stuff going on today. Dislocations in particular, whether it's traumatic or not. I have personal experience with that, so we can at least talk about that part anecdotally, what the research says. Do we meet in the middle? Is it a case by case basis? Hopefully we can share some of our insight and our experiences with you, the audience, and hopefully I'll help you with a conversation at some point in time in your career.
Yeah, perfect. Well, before we get into it, let's talk about our drinks, Brandon. What you got going on?
Doubling up from last week's Don Q from Mr. John V from NYU. I liked it. It was the Anejo XO. So I liked it. It was smooth. So I put it on the rocks and we're going to have a show with it.
There you go. There you go. Back to back. Well, speaking of back and maybe reoccurring things, I got Guess Who's Back, which is from our good friends at Neck of the Woods Brewing. Thank you, Devin. It's a golden stout, golden coffee golden stout, which is near and dear to my heart. So the hops, if anybody wants to know, are Columbus. Malt is pale flaked oats and wheat and smoked barley. Ooh, so maybe it has some smokiness to it. And I have actually Neck of the Woods Brewing cup. So that's rare that I get back to back like that. It's usually one or the other. But I don't think I had this, so I'll have to give my rating. Hopefully I'm not too much of a Scrooge. Oh, this came out different. Being it's a golden stout, looks more down towards the white stout family. So I was expecting this to be darker. Shows how much I know about beer, I guess.
I feel like golden is just another name for white.
Yeah.
They just want to sound different.
Yeah, right on the laptop. Oh,
you can't pour over the computer, man. That's a rookie mistake.
I know. Well, you were all hyping me up last time, and I was feeling confident, got a little cocky. Maybe that happens with some of these people get, dislocations. They get a little cocky. They feel good, and now you're spilling beer all over your computer, which is great. All right. I'm back in business, but and not my best pour, but there we go. Sip.
So while you're sipping that and finding out what grade you're going to give it, probably like a 7.8 or something.
No, I'm giving this higher. I can tell. This is like, remember how we had the ooh la la?
I want some of that. You got to bring that up next course.
Yeah, I'm bringing it. So this is good. This is excellent.
Good case. I'll ask Marta if she wants some too. I think she liked that too. She liked the bean one though.
The bean. Oh, that I know what the black IPA one, right?
Yeah, that was a good one too.
That was good. I'm gonna give this. I'm gonna go with it. 8.5.
Ooh,
wow. I rarely get up that high. I don't even know if I have so far.
Is it that good, or you just didn't want to give another 7?
No. It's good, and
that's the highest you've ever given.
Huh? It might be the highest, and that includes my own beer that I made. So, this is good. This is especially with stouts, to get heavy, but this is light, but it's packed with flavor, and I can tell that if it was extra cold, it'd probably even be better. But I took this from the clinic and drove all the way back and that sort of stuff. So, but I'm gonna give it 8.5. Again, maybe it'll little bit more generous in my rankings of now, but I think it's a well-earned 8.5.
8.5, and that's with it not being cold.
I mean, it's cool. It just, you can tell it lost a little bit. It's, it's 20-minute drive. Gotta get the dog, such and so forth. So, but 8.5.
All right. So my question is, are we going to keep this strictly to dislocations, or are we talking about stabilization in general?
For like people who are just naturally like
14-year-old, girl who, has some loosey goose shoulders, and their surgeon wants to tighten them up.
I mean, we can let's
Never
start
dislocated.
off with your story of maybe some dislocations, and let's see where it is. I think it'll probably be layered into some of our treatment if we can start tapping into that. Without, or we can make it a separate episode, but I think we can dabble in a little bit of both. But let's start off with some of these, your more classic dislocations. Versus our naturally lax individuals.
It's dislocations, but how is it a traumatic experience, or is it somebody who just has multidirectional instability naturally? All right, and for those of you out there,
talking off of that.
What's up?
Let's start the talk off with that. I think a lot of people don't know or are surprised with the idea that some individuals are just naturally looser. We kind of talk about gymnasts and some cheerleaders, but I know some males that play, I think actually a lot of male baseball players, they're just some natural laxity to them. Maybe that's why they get into throwing, because they can. But some pre-existing conditions like Ehlers-Danlos syndrome, making them naturally lax, and how that can lead to these, maybe not full dislocations, but like subluxations, where it kind of pops in and out on its own, and how many strikes you get before a surgeon wants to tighten you up. But maybe we'll talk a little bit about that versus our classic traumatic pops out, someone has to pop it back in sort of stuff. Brandon, you want to continue that?
Yeah. So, before I go into my story, you have your traumatic and talking about in the PT side of TUBS, for those of you who aren't aware of that, and that stands for it's traumatic. It's often unilateral, often treated with bank heart surgery as your first option. And then we have AMBRI, which is asymptomatic, multidirectional, often bilateral, and rehab is what you want to do first before you do some type of surgery. So going back to mine happened in what was it, 2011 ish?
What I met you.
I'm trying to think of the date now. I know it was the fall. Anyway, I think it was fall 2011. I was playing in a weekend baseball league. I was playing center field. Actually had two diving plays earlier where, full on, belly flop for the ball, did catch him, landed, but that's how you would typically injure it, arm up above you. For those of you who watch football, Baker Mayfield just injured his non-throwing arm like that. He was tackled by his legs, kind of landed up like that, and that has a torn label of non-throwing arm. We'll touch upon him in a little bit.
Let's see if I can.
So anyway, I had another play where I was going to do that same one, and I guess the PT in me was like, let me not. I have already had two of these. I've gotten away with it. Let me shoestring catch. So I kind of did like a baseball slide, and it was an awkward play, probably because I tried to change my my slide, last second. And I don't know, my knee hit the ground, kind of flipped over, landed on my elbow, my shoulder popped forward. Heard like the catcher. I was playing, like I said, I was playing center field. The catcher heard it. Now at the 45. So anyway, dislocated it. Got it. Went back to the hospital. Got it popped back in. They reduced me. Or it was fine. Did rehab. I guess through that whole process, I went and saw a very renowned surgeon And, I was ready to go get surgery. It pops out. We know about tubs, right? But I'm a student at this point in time, but, going by that, thinking I know a lot. Went there, was expecting surgery, wanted surgery. I had a finite window to get surgery between the end of the semester and then the beginning of the next semester / when I would actually need my arm, right? For obviously you guys in PT school, very hectic schedule. You have practicals and things like that. Basically, I would have had 6 weeks where I didn't have, from one end, the last practical, one semester, the beginning practical of the next semester. So I would have had to get it done right away. The surgeon had said, no, I don't need surgery, because at that time, I think it was 24, 25. And he said, you're at that age where you only have a 20% chance of redislocating. It's like 81 chance of not redislocating at your age. At 25 and older, you're not going to redislocate. Things will tighten up. You'll naturally kind of heal. You can rehab it. Fine. I told the surgeon, I was like, I'm very active. I play sports. I work out. I want to be able to go do all this stuff. So if we need to do surgery, let's do it now, because, I'm on timeline. So he's like, no, he kind of insisted against it. There's a very prominent surgeon at a very prominent hospital. So didn't get surgery, went through rehab, yada, yada, did, months of it, was back to feeling good and everything. Played in a snowball, which is around here in North Jersey. We go play at Giant Stadium for the cause of Special Olympics. Went up to grab a pass. Defender pulled my arm down, redislocated. From that point on, I dislocated like another 4 or 5 times prior to it. And at that point, you're in the thick of PT school, and I kind of had to suck it up until I graduated, because if you miss any time in school, at least the way my program was, they were going to put you back. I didn't want to be put back. or held back, timeline wise, things like that. So I had to, operate a year and a half, almost 2 years with a shoulder that kept dislocating. And at that point, I'd go to sleep at night and I'd wake up and my shoulder was out of its socket. And this was all because, in my opinion, he's playing the stats of my age range and didn't listen to me in terms of, I'm going to go back to X, Y, and Z. I'm still young enough, athletic enough to where I want to do this stuff. In my opinion, I think I should have been tightened up the first time. And I'm anti-surgery.
Yes.
But I should have been tightened up the first time. It would have saved me, 5 dislocations, whatever other trauma that was, damage that was caused to the labrum and rotator cuff muscles since then. So, compensating, atrophy, altered motor control, fear, apprehension, catastrophizing, et cetera, et cetera.
Yeah.
So, that is my story. And to me, and part of the reason why I think I did a residency and I'm so passionate about PTs being autonomous and doing their due diligence and listening to the patient and making your own decision is because I felt like I was mismanaged for that. And, you have to take it as a case-by-case basis. And let the research guide you, but also listen to what's going on in front of you with the patient, what they're telling you, what they want to do, what their mechanism of injury was, and things of that nature. So that's one story. I have another story. It's actually the opposite, where I was treating a patient who didn't need it and got it, and still kind of lingering some stuff to this day. But we could touch upon that in a little bit, because I think that's more of a Ambry and a developmental one as well.
So I'll have some questions based off of that, that story that you put up there, Brandon. Now, did they, so that's, I think people need to take, hopefully they listen to previous episodes and how much of a, proponent we are, and especially Brandon, for not doing surgery. And I think some big takeaways is that he was trying to, tell the surgeon, my life isn't the stats. I think that's a big takeaway there. Now, did they do MRI and everything after the first dislocation, or was it like, it was dislocated, this is it, these are stats, we don't need to worry about it? If you can.
I want to say I did have an MRI. Honestly, it's so long ago. I'm pretty sure I had an MRI. I had the x-rays from going to the hospital, because when I went to the hospital to get it reduced, They took X-rays there. I mean, there was no doubt in anyone's mind. It was, you know, dislocated and I have a torn labrum from it. I mean,
slap.
You don't get a torn labrum with that type of, or you don't not get a torn labrum with that type of
dislocation.
So
I agree.
he had it. Yeah, I guess, you know, I would love to talk to him now. You know, and you know, he probably doesn't remember me, but
Probably not.
just to, you know, what's your thought process? You know, it is what it is at this point. But you know, what was your thought process and kind of playing the stats? And I can understand if I wasn't active, if I was older, if I was, you know, in my 30s or 40s, you know, at that point, yeah, we naturally as humans just tend to stiffen up anyway. Plus your lifestyle changes at that point, right? You tend to have, you're a little older, right? You're not just naturally quite as active. You probably have a family or kids. Like, that's probably the person, okay, you play the stats on, not someone who's 24, 25 telling you they play in every weekend league that there is, baseball, basketball, football.
Maybe it was a looks thing. Maybe they looked at you and was like, yeah, this guy doesn't play enough.
Yeah, I'm gonna tell you this right now. Oh yeah, I just want to.
I know.
Oh, this is gonna come out. Just so you guys know, right now Jeremy is talking shit because he thinks he can beat myself and Kevin, who was one of our my interns. So it's going to be him and his office manager Cam versus me and Kevin. And a lot of shit talking going on this weekend on the gram. They're about to get just, you know, annihilated. They don't even know what's coming. And then on the side game is going to be Cam and I 1-on-1. And he's just going to go jump in a river once I'm done with it.
Oh, no. I'll tell you right now on I guess live here, Cam is the best of the four of us. It's whether I bring him down or not. And I'll be honest, people, again, I've just started as of this year organized basketball for the first time in my life. So, which is kind of funny. I'm talking this much shit to Brandon and Kevin.
Don't make excuses.
I'm not making excuses. I'm gonna say you're talking about annihilation, and I think we're gonna mop you up because, you know, look what I did to Kevin. I mean, he's still probably psychologically distraught.
He's rebound. He's living life.
He's living life. He's probably having some nightmares. I cook up Kevin in the clinic a little bit a couple of days ago, but yeah, you know, so maybe that doc saw something. He's like, yeah, this guy, he's running up here. His time in the athletics is short.
We're now going to at least record part of this game, and it will be put on the YouTube.
On Nips and Sips.
Sips.
All right.
For you guys to watch the massacre.
Yeah, we'll see about that. I'm not to posterize somebody and then make that top play. See, this is all based off of, all the smack talk is based off of, we do not top plays at Trifecta. And I had one very, very poor pass, and they're relying that whole not top play on my skill level. You just see.
Dude, just so you know, we're going to be playing on a 10-foot rim, not that baby room you have in your clinic.
That I know. That's something I'm a little bit worried about because I've been like draining a lot of shots, and, you know, I can hit like 9-10 in a row. I'm like, this is great, and I'm like, this is only a 9-foot rim, so it doesn't matter. I'll just outwork you both.
All right, we're
anyway, going back.
All right, shut up about your
so stay tuned for that. That should hopefully happen in a couple weeks or so. But I had a question based off that. So interesting. So you got initial imaging. I am curious, after the 4 or 5 dislocations, I guess the second time around, did you get more imaging? I am curious to see, a lot of times, did more essentially damage happen? I know a lot of like the thought process, especially ACLs, is, you know, we'll look at the research of return to sport and the non-operative versus operative. It's pretty similar, but a lot of the, you know, the purist of, hey, let's operate, is because it saves the joint, it saves other structures such as the meniscus, the less chance for chondral defects, such and so forth. So I'm interested in your case, now that we started talking about it, did they have a comparison in MRI? Did it lead to more trauma or just more loosey-goosey?
Well, I had a when I actually went and got surgery a couple years later, from actually the gentleman's colleague.
He didn't even do it on you?
What? No, he did. He didn't end up going. It was someone else. Some of it was insurance related and all this other crap. But whatever. Whatchamacallit? I had a rotator cuff tear. I had a like 15% tear ish of my supraspinatus, which he actually did not touch.
Okay.
That wasn't there the first time, or he didn't recall seeing it the first time. He also said it could have been from baseball when I was younger, but I didn't have it the first time. He said my labrum was like chewed up. I mean, you're only getting that after several dislocations.
Yeah.
So I forget how many tacks surgery. I think it was like six tacks. I have to double check. I mean, this was my surgery was 2013. It's 2021 now, so 8 years, right? Is that right? Yeah.
So I know to go after that shoulder when we play ball. That's it.
It's good now. It's good locked in.
So yeah, that's something interesting, you know, especially us being, again, proponents of trying the non-operative approach for most things. Is it, you know, looking at the lifespan and of the person, you know, is it better in certain cases to operate first versus, you know, let the person keep dislocating? And when do we stop? Brandon, I don't know. Well, first, and I guess unrelated, did you ever find the statistics on the age, or was that a purely anecdotal, his experience, the 20%?
That's what he said according to the research.
Okay. I don't know
if that's research he's done. I honestly never looked into where he got those numbers from.
Yeah, I'm curious. I haven't seen it. I haven't looked at it because I just heard about it now. But that'd be interesting to see if that's really research or his personal research.
Yeah. I mean, you figure out as the head surgeon, you know, he's probably published some stuff along the way. So it's yeah, but that'll be a good one to honestly really look into. I think the bigger thing is and it's kind of where I am, is help. It's our job as PTs to help patients navigate healthcare system, for lack of a better term, you know, and try and give them, you know, encourage them maybe to get a second or third opinion. Tell them, you know, X, Y, or Z, you know, whatever the case may be. You know, is it, hey, I don't think you need surgery. You're young. You need to grow. You need to develop some motor control. You haven't had a traumatic experience. There's no reason why I think this is going to be, you know, dislocating on you, that we can't rehab it with some motor control and strengthening, versus maybe somebody who is traumatic, depending on their sport and what arm it is and things like that. You know, can they go forward? Maybe that's a good time to segue to Baker Mayfield, because he dislocated his left shoulder, has a torn labrum, has been out, and he's going to try and play through it. Big thing is, it's his non-throwing arm. He's still having trouble right now.
Yeah, hold on. Let me see. So he's trying. That's what I was doing before, and it got a little loud. Here we go. In case anybody wanted to see. Oh, thanks.
And gets picked off. And on the interception, the return is coming back. I think it's Justin Reed. Baker Mayfield tries to make the tackle, and Mayfield.
That's why quarterbacks should be making tackles.
And on the interception.
So his body is going the one way. His arms torqued back, and
the return is.
Sorry, I don't think they break it down, but just in case you guys
want hit like the following week or two.
Yeah.
And landing on it again, aggravating it.
Yeah. So, but I believe that was the first episode, in case you guys wanted to see what that looked like. But yeah, go ahead, keep talking about. Sorry, I don't want to interrupt. I just want to explain why there was a loud noise in the middle of your previous discussion.
Yeah, I think it's our job to better understand, you know, some of the stats that are out there, to better understand where that patient's coming from. What are they trying to do? What was their mechanism of injury? And going from there. I mean, we have a kid right now who, poor guy, actually, quarterback for his high school team, last year was tackled, tore his labrum of his shoulder on his throwing arm, missed the rest of the season, rehabbed with us. Great, was doing, awesome stuff, lifting, strong as an ox, looked great. I think a first or second game this season, dislocated the other shoulder. Is non-throwing. So luckily it was a non-throwing arm, and it wasn't the surgically repaired side. So at least that was good.
Yeah.
So right now it's like, all right, I get it. It's your senior year. You want to play. All right, let's get you a brace. And luckily, the surgeon kind of agreed. It's like, all right, let's brace you, get one of those shoulder braces so his arm's not going to be really going too high. And let's see if we can get you to play, the remainder of your senior season. It's your non-throwing arm. Can we, do it with rehab, PT, AT room a lot, and see if we can get you through the season. If that was his throwing arm again, we'd probably be in the OR again, and, that'd be that. So the big thing is, all right, let's protect that side. And actually his main sport's baseball. And can we get you back to pitching, for the spring season? So that's one. It's like, okay, we're laying out all the cards here. It is your non-throwing arm. You understand what the rehab of the other side is. You understand the risks of the other side. Let's see what we can do with a conservative approach and a brace, and see if we can get you through the season at least, and then, rehab it in the off season or the winter season, and then get you ready for the spring. But I'd have to imagine, knock on wood, I hope it doesn't happen to the kid.
Yeah.
If that comes out again, are we going in? He's only 17.
Yeah. Now, so question based off of some things that you discussed. So do you believe, for throwing athletes that have a traumatic dislocation, they're young and have hopefully a more fruitful, more years of playing their sport, do you think those individuals should opt for surgery first?
A lot of variables going into
a lot of variables,
man, because it's what part of the season did they get hurt on? What's their goal? They're trying to get back for next season.
So college aspirations,
right? Is there because here's the thing: college or not, right? I mean, college is a different beast as well. But let's just say they get hurt in early season. All right, baseball's out if they get an operation, if they play baseball, but they try and come back in time for the following season. Right, we're talking about quarterbacks.
Quarterbacks, pitchers.
Right, so we're just talking about throwing athletes now.
Wrestlers also dislocate.
Well, are we talking about throwing athletes?
I would say anybody traumatic, active individual, similar to your situation. You were active, relatively young. Traumatic dislocation.
I think that the big thing with me too, here's the difference. Here's a caveat in my scenario. I only had a certain timeline to get it done. If I was a regular 25-year-old with a job, all right, great. Go to PT, try it, see if it works. If it dislocates again, great. We can go back in there and get it. Like that alternative is always there. Right. I think being in, PT or med school, right, with the setting that you're in where you can't take the time off, it was probably a bigger caveat of what maybe should have been done. Gotcha. Again, we're also looking hindsight 2020.
Yeah.
All right. So if I'm just a 25-year-old with a desk job, no, go to PT, do it for, 6, 8, 12 weeks. If you dislocates again, we can always go back in. I think that's probably your safer route. You have somebody, and you guys probably see it in sporting realm. All right, what if you rehab for 2 or 3 months, it doesn't work out, and then you got to go in anyway. Now you just lost 3 months, and you're going to miss the beginning of next season. And in high school, the beginning of next season is really the whole season. I mean, high school sports, you're looking at 8 weeks plus playoffs, not including preseason, right? So that's where things change. Professional sport, their season's much longer, maybe they can do it. They're also getting paid a lot of money. So there's all these different variables you have to consider going through it. You know, figuring out their main sport. If you have a overhead athlete who gets hurt in football, are they playing baseball? You know, are they pitching? If they're not a pitcher, can we get away with it? You know, what's the degree of it? I think there's just so many layers to it. Do they play basketball in the winter? Everyone says basketball is a non-contact sport. Not true. Jeremy's about to find out. But you know, you go for a rebound, someone yanks your arm. You know, look at Dwight Howard. Here's another one. Dwight Howard with the Lakers. You know, had a torn labrum, tried to play through it, and just kept re-injuring and kept dislocating. I mean, you have, in his case, 250-pound, 300-pound guys just ripping down on your arm.
Yep.
You know, that's someone who tried a conservative approach so he could play the season. I just think there's so many factors in it. I will say, if it's your dominant arm and you have a traumatic dislocation, and I'm talking about dislocation that leads to a tear. Now, you're looking at not just a labral tear, you're looking at inferior and medial or middle glenohumeral ligaments that are being torn as well. I mean, that's the front pocket that's kind of keeping the little anterior stabilization they have anyway. It's not so much the labral. Are the ligaments, which they typically are, on a dislocation like that, are they torn? Are they stretched out? So I think that's another thing to keep in mind as well. What other structures are compromised? I think a non-dominant arm you could probably get away with.
Yeah.
But I'd probably say at some point you're going to look at Baker. Non-dominant, played again and got tackled and landed on it again. Like, now you're just playing all season long, hurt, and trying to muster through it.
And can't deny, even if it's your non-dominant arm, that's gonna hurt like a bitch.
It hurts. Honestly, I've had a couple injuries. I'd say the shoulder was by far the worst. A shoulder dislocation, I should say. Like that hurt me the worst. The surgery wasn't bad. Everyone was like, the surgery's awful. I didn't think the surgery was fine. I was fine. In a day and a half, I was just, it just felt like pressure. But by far, I personally think the dislocation was the worst.
Yeah.
Now you take somebody who has ambry, who's just generally lax person, maybe your swimmers and they're having more subluxations and there's no actual tear. Maybe things are stretched out.
Yeah.
Here's the caveat with them though. Are you going to be able to shut them down long enough so you can actually rehab properly for like 3 months? Probably not.
And then investing into strength training. Tighten them up, which is tough in that realm, especially swimmers.
Yeah, and swimmers don't want to get bulky and all that stuff. I mean, there's I don't think there's, I mean, if I had to say, and this is probably a little biased, very biased, I think if you have a traumatic dislocation of your shoulder, you're probably going to get surgery. And you want to resume, athletics. Now, if you have it because you fell down some stairs or something and you're not, you're a sedentary person, you probably don't need it. Right. So
why go for it?
It depends what you're going for, or what the person is going for. Wrestlers, you talk about wrestlers. I don't know. Wrestlers are a different breed, man. They're not right upstairs. And I've treated some wrestlers who've had some pretty significant injuries where I'm like, I don't know how you're doing it. I had one guy who was Olympic level, and he was operating, not operating, but he was playing or wrestling with dislocated shoulder, or I should say with a torn labrum, with a history of a dislocated shoulder. He was fine. He was able to, work through it. So I had another wrestler who had, torn meniscus, who wrestled on it all season. He ended up getting surgery after, but he wasn't missing a season. So I think that's a talk you have to have with each patient, the patient's parent, the coach, if they listen, or the AT at least. Hopefully communicate to the doctor as well what you're thinking. But I'm gonna go on the side. If you have a dislocation, you're probably, and you're in sports and you're young, you should probably get it.
I agree. I think I brought up some good points that, Brandon didn't give a firm answer. You said it depends. It's really based off the patient, where they are, and that sort of stuff, versus, being fixed to one thing. Having multiple options and understand where the patient's at, I think yields the best results. So, for a diverse answer, that was exactly the right answer, I believe, if that makes any sense.
Yeah, remember in PT school when we used to ask questions and the teachers were like, it depends, and we're like, that's not an answer, and then you go out to the real world and you realize that is an answer.
That's true.
The answer. But the thing is, in school, well, depending on the program, sometimes you can or cannot get into all the variations if it depends. Hopefully this podcast sheds some light on some of the different possibilities of why it depends.
Mm-hmm. True.
Yeah.
So speaking surgery, what's your opinions on it? Did you have a Bankart repair as well, or is it just pure slap and
Yeah, he tightened me up too, though, actually.
Okay, so like
he tightened the capsule a little bit. Yeah.
Okay.
He didn't like heat shrink it at all.
Okay.
Yeah.
Makes sense. So I was curious to see your experience with how many of your individuals get a Bankart repair and then it still continues. I feel like I've seen that more of late, where I haven't seen anyone. The next process after Bankart repair is typically the ladder J procedure, and I've seen more people with ladder J than Bankart repairs of late. So I was curious to see what your opinion was on that process, or the frequent dislocators even after surgery. I don't know if you've been exposed to that.
I haven't been exposed to too many dislocators after surgery. I mean, I send there's like only like if there's a surgery needed, I send them to like, one of two, maybe three guys.
Yeah.
And one of them is actually the guy who did my shoulder. That guy took the time to listen to me. He helped me out. He explained everything. He's like, yeah, there's some other stuff going on in there, but he's like, I don't think you needed it. The rotator cuff tear, I was like, oh, did you fix it? He's like, no, he knew I was, he's like, you're not playing overhead sports anymore. So he's like, you'll be fine with a 15% tear. And he's like, and he told me point blank, he's like, I try and do as little as possible.
That's good.
And, you hear that and it's like, awesome. I find that very respectable. And then I've had, other surgeons I've talked to and they're like, yeah, I fix everything possible in there.
Yep.
It's like, and then you wonder why, I when I was starting up my own practice, I did some per diem work for a physician owned, PT place, right? I'm all against that, right? But I did it. I had to make ends meet, whatever it is, what it is. And, he was a surgeon and, I would have conversation with him of, why, I can't even talk. I would have conversation with him of what he was doing. Cause I was noticing like all these shoulders and knees just freezing. Like I couldn't get a knee past 90 degrees. Every single shoulder he operated on, was getting a frozen shoulder. And I was talking to him and I was just like, what are you doing in there? He's like, oh, I clean up everything. He was just like so matter of fact about it. I was like, okay. And he had kind of a bad reputation, so I didn't even try and say, hey, maybe you should be a little softer.
Well, less is more.
Yeah, less is more and stuff like that. And maybe today I would. This was 6 years ago. I was only 2 years out, so maybe I should have said something. Maybe not. Who knows? But you have that conversation and you see those outcomes, and then you have the conversation with the other guys who are like, yeah, you try and do as little as possible, only what's needed, and you see those results and things like that, and it's like, all right, if I have a complex case, they're going to like 1 of 3 people, and I make sure, those guys, those patients go to those docs. Anyone else, if you just want an MRI or an injection or something like that, I'll try and spread the wealth to some other docs in the area, and that's more networking and relationship building. But if it comes down to operation, I try and make sure my patients see 1 of 2 or 3 people.
Yeah, I think that's a good point. Is like we need to realize of how much trauma surgery really is, and the body needs to recover from every area. From the incision, you think it's just, oh, it's going through the skin. No, the body needs to recover from that through all the muscles. Every time they play God with every point of the joint, and a lot of the cases, unless it's a life-threatening surgical, like what they do in the ER, um, where they have to do a ton of stuff and, put your broken bones that are shattered back together, in their standard orthopedic surgeries. I think less is more. I think when I came out, the double knee replacement was a big thing. And those people, I mean, they could be going to a good surgeon and they would do both knees, but that's just too much for the body to handle. And I haven't seen one in ages. Um, I see a lot of ACLs, and sometimes when people have multiple ACL like things going on, whether it's meniscal and that sort of stuff, or PCL as well, that they stage in two separate surgeries now. I think they're starting to realize that when you play too much of God and play around with a lot of things, it ends up with worse outcomes. So do one thing at a time, or do just what you need to. I think yields a lot better results. So but yeah, it's kind of my experience. Have you seen a double knee in a while?
Not in a while. I just had a knee. She finished probably like a month ago.
Yeah, just
Um,
a single, right?
yeah, she was a single. She actually came up from Philadelphia to see me. We got her to break 90 degrees and full knee extension and walking. It was probably like, I don't know, 2-3 weeks. And then she went back down to Philadelphia, but she wanted to make sure she hit those milestones
Nice.
first. Yeah, she might get the second one done somewhere down the line, but yeah, I'm with you. I mean, you and I came out, I think, the same year, right? 13.
Yeah.
And it was like, oh, you get one, you should just get both of them at the same time, because you're not going to go back for the second one if you get the first one. And,
Oh,
you're just seeing a bunch of double knees cranked out.
it's
I'm
terrible.
sure some of that is profit related as well. But
Oh yeah, definitely. You can bang them both out. It's $100,000+ right there and then. But there's always one knee was left behind, and think about that. They got to crank out a bunch of other people, and prosthesis doesn't fit quite as well. It was
not
about
even that. I'd say down the rehab side, though,
Oh
like
yeah,
the patient can only tolerate so much in one day,
yeah.
of rehab. And
It was taxing.
so
But moving back to shoulder dislocations, Brent, is there anything that now that we kind of talked about some surgeries and anything like that, anything that you can think of, see, played around with that may either predispose people to dislocations, and or if they had a dislocation, maybe working on some things, if you're working with these people that are non-operative, some things that you want to work on to prevent any dislocations. Is there anything that you see on your end?
traumatic or no? I think traumatic is tough because, again, I think it's tough in the more active, younger population.
Mm-hmm.
I think the older population, they'll respond to strengthening, rotator cuff strengthening, working on T-spine mobility. I work a lot on the neck and the brachial plexus a lot, so a lot of neurodynamics, because think about what happens with anterior dislocation. You're stressing. Well, one, the axillary nerve is the most commonly injured nerve in an anterior dislocation, and then two, just the brachial plexus in general is right there. So there's more often than not in a traumatic experience injury to the brachial plexus. So a lot of times that will cause ongoing pain, especially anterior shoulder pain that will be attributed to the dislocation, but a lot of times it's the neck or neurodynamics. So treating that area as well. And then, just building up a lot of the muscles around the shoulder. I mean, I'll go even just like meathead stuff, like building up the deltoids, doing posterior mid delt, anterior delt flies, just really trying to get all those muscles around the shoulder blade well, getting the rotator cuff well, getting that lower trap, mid trap really going with those. And then, if you want, we could talk about the multi-directional instability patients, or the younger patients who have like scapular dyskinesis and things like that. Because I've seen that side of things too, and it's not pretty either.
No. We get a lot of those. Yeah, piggyback off of what you said. I think some stuff, especially second go around, or just overall looking at some athletes and that sort of stuff, or even regular individuals, is working on range of motion. A lot of the individuals, some people have had some dislocations, and you look at both sides and their shoulder flexion is like here, and their dislocation was like a hyperflexion injury, and they get to here and the body says, well, this is as far as I can go, and then they get forced further, and then it comes out. Or like in Baker Mayfield, where he's coming back and then he had that anterior dislocation from reaching back. Having some more range of motion, whether that's something neurodynamics, this is median nerve, upper limb tension test, thoracic rotation too, being able to stretch yourself and rotate backwards if a force is coming. A lot of times, especially the quarterback, they're coming and then they get tackled and get brought back this way. Having more rotation beyond just most of them have adequate external rotation of the shoulder, but having like rotation through the thoracic spine, or again more flexion or ability to reach overhead, I think helps, especially from the rehab process, but also from anytime the going into the second dislocation or preventing the second dislocation. Luckily, we've had a good results with those, but those are some things I see. And then I agree, working on some things, working on core as well. I think a lot of the movement, absorption of force and transmission of force. So we do like a lot of core work versus just pure parascapular stuff. I think that's something that's commonly missed in those programs.
Oh.
But yeah,
I will say, and just talking about our talk here, what's your experience? And I think part of this is we, a lot of times we don't get too much of a saying in the treatment. I mean, if the doctor said or the surgeon says surgery, the patient's gonna go do that. But either post-op or trying to avoid operation, what if you're talking about range of motion, what if we immobilize the patient for 6 to 8 weeks to allow things to heal and stiffen them naturally? There's talks of putting them out at neutral to 45 degrees external rotation, and letting them heal that way. Can you see me there? All right, that way, versus having them here, which is what we typically do with our dislocated patients. If we put them out here, will that help that kind of avulsed labrum and the proximity to everything kind of heal better? And I think that article, let me see if I can pull it up here, was by Deley or Dell, Deyle, right? In like 2007.
Yeah, it's an older article.
Was talking about that,
the outcomes post-op, whether
yeah. So
I remember that was some discussion in residency. I think Scott also had a labral repair, and he's talking about when do we start to go crazy with mobilizations and that sort of stuff. I remember early, I was like, from what I remember, most articles or for most orthopedic things is early mobilization tends to be superior, but he brought in the everything's a balance. It's when can you, and if you start going crazy with early mobilizations on someone who's freshly dislocated or fresh post-op, and you start to overstretch things before they heal, are we setting these individuals up to redislocate or have another injury? So that was eye-opening for me, because I usually at that time was like balls to the walls, 0 to 100. I'm gonna hit all my milestones in week 1 because I'm that badass of a PT. And then it was just like, no, you need to respect healing timelines of tissues, especially in the shoulder. But I don't know if you have that article or.
Yeah, I have the article. Scott was also, he's a little older than us. He had the capsule, the thermal shrinkage though.
Yeah.
Which they don't even do anymore. But they used to shrink that capsule too much, and he never got back a lot of that motion.
Yeah, he was like here.
Comparing battle wounds basically at that time. So I found it. It's shoulder position and neutral to 45 degree external rotation helps reduce the avulsed labrum, bringing labrum to close proximity to the glenoid rim, right? Versus a typically internally rotated position where the lesion is not able to heal. They're thinking that it's a plausible idea that immobilizing the shoulder in a more externally rotated position could result in better healing of the volus labrum. What they did with this patient is, they had torn capsular ligamentous labral structures, not healing. They immobilized them for 6 weeks with protected activity for another 6 weeks. So right there, you're looking at 12 weeks of basically immobilization or controlled immobilization to allow it to heal. I mean, if you're playing athletics, you probably don't have that time to see if it can work versus not. So I think that person was able to resume everything without any other symptoms of instability. They did that 20 months. They had about 13 weeks after that dislocation. They had full active and passive range of motion, near normal strength, things like that. That goes into, we've had talks about ACL tear, Coper's ACL, and things like that. With the outcomes not being as great as we once thought.
Yeah, so I haven't seen as much of that in the shoulder, which is surprising because it's the most dislocated joint. You'd think they'd do more kind of comparison studies versus, and you said this was a case study, right?
Yeah, it was a cage sport.
Yeah, I thought they did more. Another study where it was looking at the outcomes with the different type of bracing. But yeah, so all some interesting things to think about in regards to how fast we progress, people, how slow. Again, I used to probably go too hard, too quick, and took some wising up and that sort of stuff, respecting all.
I mean, even if you think about post-ops, how fast are people trying to get range of motion? Like sometimes you just need them to heal.
Yeah.
And if you actually, I've noticed this recently with post-ops, that their surgeons are tend to become more conservative with them.
Yeah.
And delaying it and not wanting you to do too much too soon. I've definitely seen that on the Achilles side. I've definitely
ACL side.
The shoulder side, ACL, like, hey, let's not crank away at some things and let's let things stiffen up naturally. They're going to get more motion as time goes on. However, as time goes on, it tends to be, you're looking at a year and things like that. How often are you getting to keep a patient a year past, surgery? Not too often.
Yep.
So maybe it's discharging them and then having them come back later on to finish up some stuff, because, chances are maybe once you get them, to the point where they have, 0 degrees of range of motion and strength is good and they're able to function, maybe take some time off and then come back in. So there's a lot, I think, that hopefully the next decade we'll be able to better uncover now that PT is beginning to maybe hit its stride and the ability that, and all the things that we can help with.
Yeah, I mean, hopefully. I know we had that conversation last podcast, which hasn't been released yet, about what, where we are and that sort of stuff. But yeah, hopefully it continues to get better, and hopefully more research comes out on, we have a lot of things about guidelines and those sort of things, and it's a lot of it's like, months in, but can research help us even within the months, within the weeks of, particular things? Because the very opposite can happen. I mean, how many contractures have we seen and those sort of things from failure to push too much, or failure not to push enough. So it is a fine balance, and, it goes back to that. It depends, and every patient's different. But, I think, keeping on top of your patient and monitoring their symptoms, and again, understanding the surgical process. I think it's important. I mean, for us, we always ask for the post-op report, and just to get an understanding of all the structures that are healed. I'd say shoulder more than anything. I see a ton of knees, but shoulder more than anything is on that script. It says one line of something, but it's legitimately they do 3 different surgeries, and that's maybe even the conservative ones. Like I've had so many people are like, oh, they just did a little cleanup. I'm like, no, they did a cleanup. They shaved off your chromium. They did a full cuff repair. How did you not know about this? And they get hit with a brick wall of why they're not, moving
I
as
think
quick
it's
as
fun
they can.
surgery. I mean, surgeons need to not be like, oh, we just cleaned some things up and that is that. Tell me what the fuck you did. I hear that all the time. That doctors just say, oh, we just cleaned some things up. All right, well, what does that mean?
I guess there's some balance between not trying to freak out your patients and add some nocebo things that we fucking list around a lot of things, and there's a balance.
That you're gonna do, they're not gonna get surgery.
Mhm.
If they knew.
It's true. And now it used to be, from what I know, it used to be you're forced to watch the video of whatever surgery you have. Now it's back to optional. Like people are like, I ain't watching that. I refuse to, because again, most people probably won't actually do it, because if you're in orthopedics or sports or whatever, I think any PT, if you have an observative surgery, make sure you go about doing that, and then you get a real appreciation of what these patients are going through. Doesn't matter. Even arthroscopic procedures, which are always labeled as not as intense or whatever, you start looking at what they're doing and what they're burrowing out and drilling in, it's still a lot. Or here's top it off, and this can be my last remark: a non-invasive invasive procedure. Someone explained that to me. So a Tenex procedure, which is I believe a rotator cuff, not exactly a repair, but they're cleaning up, again, the cleanup of the tendon. So if you look at arthroscopic, and it looks like flailed meat or like fish meat, and they essentially cut around the tendon just to keep what the more cleaner looking tendon left. So that's a Tenex procedure, but is labeled as non-invasive procedure. And then literally a sentence later, they talk about invasively going into the actual shoulder. I'm like, which one is it? It's invasive or non-invasive? Like, if you're going into it as something as small as a little hypodermic needle, that is in theory invasive. But that's kind of the state that we're in, is like less is, if we can explain less and it's not that much, then people will sign up for it. But Tenex procedure, if anyone wants to look that up, non-invasive invasive procedure.
Real quick, just before we're getting long in this podcast. I had she was at the time 13, girl, overhead athlete, played 3 sports. Volleyball was her main one, volleyball and basketball, so 2 overhead sports. Came in with scapular dyskinesis, some laxity in the shoulders, but 13-year-old girl who's in the midst of growing, poor motor control, having shoulder pain. The surgeon maybe gave her like, I don't know, a couple months of rehab, and went in and tightened her up. Like, what are you doing? You have a 13-year-old girl who's in the middle of puberty, with clear scapular dyskinesis. Like, she couldn't even hold herself up in a tall plank position without like just collapsing. And you're going to go do a capsulorrhaphy on her for what? And I still see her to this day on and off. She plays college volleyball at this point, and her shoulder will flare up from time to time with her. And he tightened up so much so her collarbone would kind of rotate upwards. So she had this like popping forward that we kind of had to like mobilize the crap out of that and the shoulder to get it to kind of not happen anymore. But when she doesn't do PT, she's a really good athlete, so she kind of slacks off on the strengthening side, which she knows she does. I think that would fix a lot of her stuff too. But when she plays a few weeks or middle of the season, end of the season, she'll come with the shoulders are tight again because everything's trying to compensate, and we got to clear some things back up again. So that's a case where you have somebody who would probably fall into the Ambry aspect, who's never really given a chance. And forget rehab. Like, honestly, I think she would have just gotten better with a couple years of just maturation. But here we're in rehab to at least expedite that process. The guy had the same doctor I was telling you about before goes in and does way too much. And my opinion, not only did he tighten her, I think he over tightened her. Someone who's in the middle of growing, in the middle of physically maturing, and who's never had a dislocation. She probably had a little sublux. Maybe that glenoid was kind of riding on that front rim, but I think that cleared up. As she got stronger and got some more tone in her muscles and things like that.
Absolutely. Yeah, that's a scary thing. Is what happens when they over tighten. Seen that in shoulders, seen that in ACLs.
Too vertical,
they're stuck, not being able to do what they want to do because ligaments are too tight and that sort of stuff. And everybody I've known that I've seen that, it's just like, no, like they think, well, I guess we can go back in and loosen it back up. They're like, no, it's not worth it. So it's a shame, especially in those cases where probably just need, time, maturity, maybe occasional weightlifting program, but and hopefully with things in research we can become more standardized of like, this is the cutoff that you'll need to have surgery, and ages, amount of dislocations, what style dislocation, sports activity level. But being that everybody's so unique, we can't wait to rely on that. It's gonna have to be our decision. What Brandon said, I usually say we are the quarterbacks for a lot of people, especially for direct access providers. Guide them to the right provider, help them make the best educated decisions. But anything else on dislocations? That was great. All right, well, Brandon, I don't know if you want to talk about any closing remarks or anything like that.
Yeah, just a couple announcements. We have last 2 courses coming up. November 6th is our 1-day extremity manipulation course, or HVLA course. So we go from great toe up to shoulder or scapula, teach you various techniques for that. And then we have our spinal manipulation December 3rd and 4th. Awesome course. That's usually a sellout for us. And if you're in New Jersey, credits are due soon. So if you need some credits, I think that one has 17 in New Jersey. So you get a whole bunch of them in one weekend.
There we go. And then, soon the 2022 schedule will be out. So by the time this episode drops, hopefully you'll be able to decide for next year. Better to stay on top of it, pick the weekends you want to do versus the bum rush at the end of a credentialing or licensing cycle. So exciting stuff for 2022 about to drop. But thanks for tuning in, and cheers everybody.
Cheers, guys.